Hello. Thanks for joining us today. You're among 2,200 emergency physicians, critical care and primary care physicians, EMTs, and other clinicians who registered for today's popular webinar. Good morning, good day, and good evening to you, depending on which corner of the world you call home. Welcome to today's live webinar, POCUS for COVID and Beyond, Diagnosing Lung, Cardiac, and Thromboembolic Diseases. Today's guest speaker is an internal medicine expert. Dr. Arishenkoff will teach us both basic and advanced POCUS applications to confidently diagnose patients suffering from COVID and other pulmonary and cardiac diseases, including a deep dive into pleural line abnormalities, focused cardiac scanning, and DVTs. In a few minutes, we'll introduce you to Dr. Shane Arishenkoff, but first, let me introduce you to your host. Dr. Aron Frankel is trained in emergency medicine in California. A very passionate POCUS educator, Dr. Frankel has been using point-of-care ultrasound his entire career. He now practices in a busy academic teaching hospital in Vancouver as an emergency physician. When he's not saving lives, Dr. Frankel serves as chairman of our Clarius Medical Advisory Board, helping deliver educational content like today's webinar, and also video tutorials for our new Clarius Classroom, which now features hundreds of videos. Dr. Frankel, welcome.
Hi, Janez, thanks. It's good to be back. And today's topic is near and dear to my heart, something that I practice essentially daily in emergency medicine, and I imagine many of you are really interested in. So let's jump into it. I did a really broad literature review in trying to set up today's webinar. And, unfortunately or fortunately, there are literally thousands of studies that can be found on lung ultrasound and several hundred at least in the past year on ultrasound in COVID alone. And we're a year into the pandemic. We've learned so much that began in hotspots and has radiated outward. It was hard to choose top studies just to review some key findings to set up our conversation today. One that we wanted to just highlight was the comparison of ultrasound to chest CT. We know now that chest CT is likely the best test in combination with PCR for COVID. But what we found over and over again in the literature is that the ultrasound seems to perform almost on par with the chest CT itself. And I imagine many of you don't have CT readily available, especially depending on where you're practicing, if you have it at all. And we know that PCR testing, even in the best scenarios, have delays to getting diagnostic answers. So we've learned that also getting patients in and out of the radiology suite that we have to do to get those CT scans adds risks to our other patients, to our staff, and it requires deep cleans, often with these UV robots and things coming to the different rooms, not to mention just the radiation exposure from the CT. And starting with the Italian experience and moving outward, we really found that the ultrasound just seemed to really be so much superior to most of our other tests, and certainly better than chest x-ray. And it was easy to clean, it's portable, and we can take it not only to different institutions, but from the hospital to the clinic and even to home visits and beyond. And particularly for low resource environments, it's proven to be a real game changer. Some of the other things we found on the studies was that not only did lung ultrasound predict COVID with almost really high sensitivity and specificity compared to CT, but it also predicted the clinical course. When they started looking at the number of patients getting hospitalized, they mostly or almost all universally presented with lung ultrasound pathologic findings, and that you could actually score those findings to predict how sick the patients were, even predicting the need for invasive mechanical ventilation and a predictor of mortality. So to have point of care ultrasound to be this intense diagnostic and prognostic indicator is hugely important. And then what we know in the point of care ultrasound community is moving beyond lung, the ultrasound can also be applied to other organ systems. And one of the things I found that really was surprising in the COVID era is we're moving beyond COVID. And when a society like the American Society of Echocardiography comes on board and has a protocol that includes point of care ultrasound, we know that this is a mature technology and it's here to stay. To have the cardiologists on board that, getting a quick hemodynamic assessment with lung and cardiac scanning in this era is pretty significant to have such a huge society behind us in using this technology, and saying that even in their algorithm that potentially no further diagnostic testing is required if you have sufficient evidence from a point of care ultrasound of hemodynamic changes that can explain a diagnosis. Lastly, my favorite study we came across, in doing the literature reviews and in all my educational work, we've found over the years, study after study, ultrasound compared to other diagnostic tests But there was one, we wonder, what about our baseline diagnostic test, the stethoscope, this tool that's been around for 200 years, and it's kind of all we have in the clinical encounter until the point of care came along. And it was surprising and not, well, maybe not so surprising to learn that the ultrasound, maybe really it is prime time to replace the stethoscope and to have actually data behind it, that the findings are so much more reliable on the point of care ultrasound with regards to interpretation, especially in critically ill patients in the loud environment of acute care. And considering then its ability to scan other organs, which this study didn't even get into, it really sets the stage for moving beyond our traditional tools and into a modern technological answer to diagnostic testing. And so who better to bring us some deeper dive knowledge into how to use the ultrasound and how to really interpret the findings than Dr. Shane Arishenkoff, a friend of mine and a general internist and member of the UBC Division of General Internal Medicine. He completed his GIM fellowship at the University of British Columbia and then finished a one-year fellowship in point of care ultrasound at the University of California, Irvine. He works clinically as an attending physician at Vancouver General Hospital, and he is the point of care ultrasound lead for their clinical teaching unit, where he focuses on resident training, curriculum development, and research. Dr. Shane, over to you.
Thanks, Oron. I will always jump at the chance to collaborate with Oron, and I really want to thank the Clarius folks here just for organizing this.
Shane, how long have you been doing ultrasound?
Well, I started when I was at least a little bit when I was doing my residency training. Our program director was, I think, an early adopter, especially with respect to internal medicine. And he helped me identify then a place where I could get some extra training, which ended up being at UCI there, and then come back to the program to help build the ultrasound training within internal medicine at UBC. So I'm going on probably 8 or 9 years here now using ultrasound in a big way. So let's get right into the objectives here. We'll go over some lung scanning tips that can help you produce high quality lung images. Lung scanning allows you to look for a wide range of pathology, but today we will focus in on the interstitial syndromes and talk in depth about B-lines and other features that can help us distinguish between cardiogenic and non-cardiogenic interstitial diseases. We'll go over lung scanning for COVID pneumonia, talk about a cardiac case in detail, and then finish off with some DVT scanning. So what is it that we look for when scanning the lungs? I break it down into 2 areas. Number 1, the pleura. And number 2, what's deep to the pleura. We will go over a detailed assessment of the pleura and learn how features of the pleural line can be informative about disease processes that affect the lung. And just notice here how crisp and clean this pleura is, how thin it is. And then we get these A lines emanating below it. Next, we'll go deep to the pleura and talk about A lines. These are these horizontal reverberation artifacts that happen when you have a soft tissue, mostly air interface. B lines, which are these vertical artifacts that start at the pleural line. And these suggest then that the interlobular septae are thickened or that you have an interstitial syndrome. And then consolidation, which is this hepatized region of the lung down here where the lung takes on a soft tissue appearance, suggesting then that you have airspace disease. And finally, pleural effusions, which we can see over here on the right, where you get the anechoic appearance of fluid within the chest cavity, and often associated with atelectatic lung, as we see here, that also takes on that hepatized appearance. So what kind of information can the pleural line give us? I look for lung sliding. Is it reduced or is it absent? And this goes beyond just pneumothoraces. The contour of the pleura, is it thin and crisp, or is it thickened and irregular? And subpleural consolidations, which are these small areas of hepatized regions of lung just deep to the pleural line that don't quite constitute a full lobar pneumonia. The other thing I want to get into detail about is our B lines. And when I think about B lines, I think about the number, because the number often correlates with how significant the disease process is. Number 2, symmetry. Do you see B lines in one lung zone on the right that are very similar to what you're seeing on the left? The gradient of those B lines in the disease state cardiogenic pulmonary edema, we often will see a gradient that is dependent, meaning that we have more B lines as we descend into the dependent regions of the lungs. Skip areas, which are areas of normal lung that are right adjacent to areas that are clearly diseased, and then the movement of the B lines, which is associated with the movement of the pleural line. So when I set up for a lung scan, I think about all of these things. But in the name of time today, I just want to go over a couple of things. First of all, optimizing our angle of insonation. And then as we get into the cases, talking about interrogating the pleural line and interrogating that subpleural region. So in order to produce a high quality image of the pleural line or to produce A lines and B lines, we have to make sure that we optimize the angle of insonation in order to produce that quality image. And so what I want to do is I want to use this CT scan here to illustrate the concept of beam orientation or the angle of insonation. I'm using these red arrows here to indicate or represent the ultrasound beam as it comes towards the pleura and then reflects away from that. The pleural line itself forms an interface between the soft tissue of the chest wall and the lung, which is mostly air. A soft tissue air interface creates a hyperreflective surface which the ultrasound beam does not penetrate. When the ultrasound beam strikes the pleura at a perpendicular angle, which is meant to be shown here on the left side of the screen, it will reflect at a perpendicular angle, and most of the beam energy will return back to the probe, producing a high quality image of the pleura and revealing important artifacts such as the A lines or B lines if present. When the ultrasound beam strikes the pleura at an oblique angle, as seen over here on the right side of the screen, much of the beam energy will reflect away from the transducer, degrading the image of the pleura and obscuring artifacts, which will render the image often uninterpretable. So to go over some of these important features, what I want to do is just delve right into a case here. Case one is an 80-year-old gentleman. His past medical history includes asthma, an NSTEMI. He presents with shortness of breath, fevers, and a cough during a period of high COVID prevalence. He had URTI symptoms here a couple of weeks ago. He tested negative for COVID early on in the illness and has been at home. Subsequently, he started to feel a bit better, but now feels worse again over the past couple of days and has presented to hospital. When he was first seen, he was sitting 79% on room air. His heart rate was up at 105 and regular, and his temperature was 38.8. He had mild work of breathing at rest, but not in distress. He has no real other contributory findings. When we looked at his investigations, there wasn't much to be seen. His white cell count was normal, although he did have a slightly decrease in his lymphocyte count. His repeat COVID test was pending, and his ECG was not really contributory. A chest x-ray was done and it was helpful. In this particular chest x-ray, we do see abnormalities in both lung fields, these ill-defined patchy opacities that certainly are in keeping with infection. And so based on this chest x-ray and the above information that we had gathered, despite the fact that he had a negative COVID test, our differential diagnosis still certainly included COVID. And yes, indeed, COVID. And potentially, of course, other respiratory infections or inflammatory illnesses that could do something like this to the lung.
Like more COVID.
Exactly. At this period of time, 100%. And so when we started thinking about this case here, we wanted to reach out or look to the ultrasound to help us better sort out the likelihood that this was COVID and that the negative test was just attempting to mislead us. And in doing so, I'd like to talk about this a bit further and highlight this study here in chest because it does a great job describing lung scanning protocol, as well as describing the lung ultrasound features of COVID. And just quickly to point out, what they did in this particular study is they suggested that the anterior lung zone in multiple rib spaces should be scanned. The lateral lung zone here in the mid-clavicular line should be scanned, as well as the posterior lung zone between the spine and the scapula. In addition, they paid particular focus here to those dependent regions of the lungs. And so they really looked to the literature to help inform where the lung ultrasound should be placed to find the features that are associated with a COVID pneumonia. And the literature did suggest that there's very frequently there are findings in this posterior and dependent regions of the chest that we need to be aware of. And so those anterior and lateral lung scans that we often see in the context of pulmonary edema, a cardiogenic cause of the pulmonary edema, were probably not good enough. The other thing that that study nicely did is it talked to us about those types of findings that we'll see with the ultrasound that suggest COVID. And so if you look over here, this is a figure from the paper itself where they show this ragged looking pleural line. Over in D here, this ragged, lumpy, bumpy, and thickened pleural line. And if you look down here in F, there's this area, this small little area of subpleural consolidation just deep to the pleural line. And all of these features were something that were commonly seen in COVID pneumonia, in addition to the B lines that suggest that that interstitium of the lung is also affected. So if we take this information then and go back to our case, let's look at the lung findings that our 80-year-old gentleman had. And so starting up here in the upper chest on the right side, what we can clearly see is a very thickened, lumpy, bumpy, or irregular looking pleural line with multiple B lines cascading down, almost forming a complete lung whiteout. The other thing that I think is interesting is that you almost see this stochastic nature of the movement of the pleura, which I often see when you have reduced sliding or a stickiness of the pleura. Moving down to the next zone here, we see once again that this pleura is affected, less B lines than we had previously though. And then I just decrease the depth here just to really zoom in on that pleural line to interrogate it well. And you can clearly see just how thick that pleural line is and that lumpy and bumpy contour that we see along that particular region. Moving on to the right lateral and posterior lung, what we can see here in the axilla is this rather preserved looking pleural line, not as lumpy and bumpy, not thickened, and associated with a nice A line here. There does seem to be a couple of B lines hanging off the screen here, but very different than what we saw in the anterior chest. And I would suggest that this is a skip area or a spared area where we have a region of normal lung sitting right next to a region of lung that was clearly abnormal. Moving down to the dependent regions here, I always like to come down to the diaphragm and the spine, where if I can demonstrate that that spine doesn't continue on up into the chest, that there is no pleural effusion present in this most dependent of regions. And then just popping my transducer up a little bit from there, I come to a region of lung here where once again, I don't see a whole lot of B lines, and that pleural line does seem a little bit smoother. And so now we've come down to a more dependent region, and we see clearly that this area of lung seems to be much less affected as far as the number of B lines compared to the anterior zone, suggesting that there is no dependent gradient to the number of B lines here. Coming to the posterior zone, we can see that this lung is particularly affected here, almost a nice lung whiteout. Down to the costophrenic angle, we see a little subpleural consolidation here as we get towards the diaphragm. And then just popping up above that, we see one more region here where the pleural line is clearly abnormal. So not to belabor things, but I'm going to go through the left lung here now a little bit more quick because we see the same types of findings with this abnormal pleural line and multiple B lines. Here zoomed in once again. And then over here down in the lower portion of the anterior zone of the left lung. And we're demonstrating that this indeed is a bilateral process, that the lung is affected in multiple areas with this abnormal pleural line and multiple B lines that are associated with that. The one last thing,
that posterior scan was the big change in my practice. I feel like for this, learning from the pandemic, as all the studies suggested, it had such higher sensitivity if you include that, and most of us didn't include that in our scanning protocol before.
Yeah, well, totally, and because a lot of the previous lung scans came out of looking for pulmonary edema, but this is
cardiogenic.
Cardiogenic pulmonary edema, exactly.
Mm-hmm.
And so that's a great point too, because I think what this very last image here demonstrates is this nice area of consolidation, a little bit bigger than what we had seen previously with these punctate bright areas within that region of hepatized lung that we refer to as air bronchograms. And so ultimately, when we just summarize what we found here, we have a pleural line with areas of reduced lung sliding. irregular thickened pleural contour, and subpleural consolidations, most prominent in the basal and posterior regions of the lung. B lines are present, greater than or equal to 3 in multiple lung zones bilateral. There's a heterogeneous pattern with no clear dependent gradient and spared areas. In addition, despite all of these B lines, no pleural effusions. So how do we then incorporate that into our case? I think this article in in intensive care medicine did a really good job of that clinical integration piece. And what they described here were high probability lung scans and low probability lung scans. Their high probability lung scan they described as bilateral multifocal heterogeneous B-line pattern with peripheral consolidations and irregular pleural contour with spared areas. And they suggested if you had this lung scan in a high prevalence period for COVID, that the specificity was around 90%. And one of the comments they made was that if you have a negative COVID test, you should think again, because we all know that those COVID tests are associated with false negatives. And when you have that high probability scan in a high prevalence period, we got to think COVID. So how did we put this together then? High prevalence, consistent clinical story, and high probability lung scan. Of course, other infectious or inflammatory conditions had to be considered, but our patient was kept on the patient under investigation unit for presumed COVID and was initiated on dexamethasone and antibiotics. In the end, 3 swabs were done and all were negative. A CT scan was done and RESP was consulted for a bronchoscopy. And the BAL specimen there for microbiology was negative, including the COVID. Ultimately, the case was tough. And we all felt that the patient probably did have a viral or bacterial pneumonia at some point and potentially even still COVID. In addition, the CT pattern in the end also raises possibility of an organizing pneumonia. So one of those sequelae that we're seeing very commonly here in COVID, and respirology recommended an extended steroid taper. Ultimately, the patient did well. He had an extended period of hypoxia, but with the steroid taper, we did see improvement over time.
So are you suggesting that the ultrasound findings would persist potentially much longer than like the PCR positivity of the COVID testing?
Absolutely, absolutely. We definitely see that. And the truth is, I guess I don't know how to interpret that COVID test at 2 weeks or 4 weeks or whatever it might be. Sometimes you have persistent DNA, sometimes you don't.
Yeah.
And ultimately, I think this COVID scan, what the scan told us was that there was likely COVID there. And even if we can't prove it, he went on to develop what looks to be a complication there related to COVID. I just wanted to quickly show this one table here. We won't go over it in detail, but it was released in the Cleveland Clinic Journal of Medicine just here in June. And they did a great job of summarizing these findings associated with different types of interstitial syndromes, and then showed the patterns that you see from cardiogenic pulmonary edema to those non-cardiogenic causes, including interstitial pneumonias. A particularly powerful tool to sort through this and differentiate between those cardiogenic and non-cardiogenic causes. So I do want to keep moving though, and we'll get on to case number 2 here. A 99-year-old female, infrequent healthcare contact. She's got CKD with a baseline creatinine of 180. So on only ASA and has had 1 week of progressive generalized weakness, functional decline, mild confusion, and decreased PO intake. She has spent the last couple of days almost exclusively in bed. She's in no distress, has no work of breathing that's visible at rest. The initial team that saw her suggested that the cardiorespiratory exam revealed an irregular tachycardia, otherwise no significant findings. They did mention, however, that she had a bit of coolish extremities, but no modeling. Her vitals were remarkable for atrial fibrillation with rates into the 160s. And despite that high heart rate, has a blood pressure in the systolics 160 to 180 range. She was sitting on room air and afebrile. Her creatinine was slightly up, and probably one of the most significant findings that we saw was a lactate that was 4.8, and she did have a small anion gap to go along with that. Here is her chest x-ray. Now I see Oron laughing a little bit here, but this is typically what we're dealing with in the emergency department in these sick patients who get an AP film in a sitting position without a good inspiratory effort. I'm not sure how much we can get out of this chest x-ray, but I think we can probably all agree that there does seem to be some bilateral blunting of the costophrenic angles, maybe a little bit of something in the fissure here, but let's be real, this is pretty unhelpful. The team initially felt that the patient was in decompensated heart failure precipitated by uncontrolled tachycardia and given IV Lasix and metoprolol. Her follow-up blood work a few hours later revealed an increase in both her creatinine and her lactate. And what does this usually do? Then a reflexive change in the strategy. We go from Lasix now to crystalloid. And over the next 48 hours, the patient received PO metoprolol, further Lasix, and small fluid IV boluses with fluctuating but persistently elevated lactate and climbing creatinine. It was at this point in time that we were asked to drop by and scan her to see if we can identify some extra data that might be helpful. So just in the name of time, I'm going to focus on the cardiac scan, but what we saw with the lung scan were bilateral, moderate to large, simple pleural effusions in dependent regions of the lungs. She had a dominant A-line pattern with normal pleura. Her IVC showed a maximum diameter of about 1.7 centimeters. This was a small lady. Collapsibility index of less than 30%. And in the short axis, her IVC was ovoid rather than spherical in nature. And the reason I point that out is I often see really spherical looking IVCs when somebody's got really dramatically elevated CVPs or right atrial pressures. So let's get right into the cardiac scan. And I like to start with my parasternal long axis. So in this particular image here, I like to start by just getting a rough sense of what the overall ejection fraction is. And eyeballing it is a good place to start. And I suggest here that we've probably got at least a mild, even up to moderate reduction in her ejection fraction or systolic function in this particular location. I also look just at the change in the diameter here of the left ventricle, this idea of the fractional shortening of diameter. And I would suggest here that the change is definitely less than 20%. I also look at the thickening of the myocardium, and I don't see that myocardium is thickening up during systole as much as I would expect, suggesting maybe that the health of the myocardium is not quite there. I look at the anterior leaflet of the mitral valve, or this idea of EPSS. How close does that mitral valve get to the interventricular septum? And it's staying well away from there, well over a centimeter in the separation there. The one thing, though, that I notice is that there is some fluttering of the anterior leaflet of the mitral valve, suggesting then that there might be a regurgitant jet coming back through that aortic valve and perhaps inhibiting that valve from opening further. The other thing that I look at is just the overall chamber sizes, and the rule of thirds I find is something that is quite helpful. The RVOT seems to be similar in diameter to the aortic root. However, the diameter here of the left atrium does seem to be much bigger. This suggests perhaps that there's a chronic increase in the LV-EDP, perhaps associated with diastolic dysfunction or the systolic dysfunction, or that there might be mitral regurgitation that has led to that increased size of the LA. Finally, I don't see any pericardial effusions present here. So we went on to put a bit of color over that aortic valve. And what you can see is that during diastole, we do see this jet that squeaks back through that aortic valve back into the left ventricle. So there is aortic insufficiency. It's not filling a great portion of this LVOT, so at least not severe in nature, but this isn't the best projection to quantify that. We went on then to look at the mitral valve, and you can see here a little bit of a blue jet that's directed a little bit posteriorly here and into the left atrium, suggesting that we at least have mild mitral regurgitation, certainly not anything severe, judging by the volume here of the left atrium that jet is filling. We also noted that the myocardium seemed to be thickened. So we took a caliper here and just placed it across the interventricular septum. A normal interventricular septum myocardial width should only be about a centimeter. Hers was 1.5. Once again, suggesting perhaps that this patient had diastolic dysfunction on the basis of concentric hypertrophy. This is one of the peristernal short views that we took. And you can see again, thickened myocardium with a really large looking papillary muscle there. I think it nicely corroborates the fact that the ejection fraction is just slightly down, and I don't see any bowing or flattening of the interventricular septum. The apical views are tough. They're always tough. And here we get a pretty good look at the heart, however, missing quite a bit of the right ventricular free wall here because of shadowing from likely a lung. And then we've got the LV lateral wall here hanging off the side of the screen. But what the peristernal views can be particularly helpful for is looking at those regurgitant lesions. And you can see here that we've put it over the tricuspid valve, and we've got a blue jet that's coming back here all the way to the posterior wall of that right atrium. It also appears to be filling a large portion of that chamber, upwards of maybe or close to 40%. So I would suggest that we've got at least moderate and even maybe severe tricuspid regurgitation. Coming down here, we've got the mitral valve. And once again, we can see that we've got that blue jet coming back, maybe not quite as severe as what we were seeing there in the tricuspid valve, but probably based on the volume of this atrium that it's filling in the realm of moderate regurgitation. And finally, we went ahead and put the color over the LVOT here in the apical 5 chamber. And we can see the aortic valve here and this red jet that's coming back during diastole. And it's starting to fill a little bit more of that chamber, suggesting once again that we probably are nearing at least moderate aortic insufficiency. So how do we then incorporate all of these great cardiac images into our clinical case? And what struck us the most was this patient had that elevated lactate, elevated creatinine, a change in her mental status. This all seemed to suggest to us that there was a state of global hypoperfusion. And despite the fact that she was hypertensive, perhaps she was bordering on shock here. Her lung ultrasound was helpful. It showed bilateral pleural effusions and a dominant A-line pattern. Bilateral pleural effusions are generally are often associated with heart failure. So we thought that that was supportive of something cardiogenic in nature. However, this A-line pattern suggested that there wasn't significant left-sided congestion. In addition, she had those bilateral pleural effusions, which we know can increase intrathoracic pressure. And this can have hemodynamic effects as well, which we'll talk about in a second. Her IVC was in keeping with elevated right-sided pressures, but the moderate TR and the pleural effusions, which as we mentioned, increase intrathoracic pressure, must be taken into account because perhaps it's not just increased right-sided pressures alone that are causing that increase in the IVC size. She had no evidence of edema elsewhere. So taking these two things into consideration, we were not convinced that congestion was enough to explain her degree of end organ compromise. I really felt that the cardiac scan was where it was at in this particular case. We were able to demonstrate that likely she had that LV concentric hypertrophy. And this is in the context of atrial fibrillation, where we need to consider the impact that that rapid heart rate will have on her LV filling time and thus cardiac output. Secondly, she had regurgitant flow at the aortic and mitral valve, probably at least moderate in nature. And we had to consider this in the context of her elevated blood pressure. That effect of afterload on these regurgitant lesions could increase the regurgitant fraction and further impair cardiac output. The increase in her intrathoracic pressure with those pleural effusions can have effects on the diastolic and systolic function of the heart. And finally, she had a decreased LV systolic function, at least mild, maybe even moderate. And so she already was predisposed to decrease in cardiac output and wasn't going to tolerate these additional insults well. So our interpretation integration then of all of these findings were that the ultrasound findings were supportive of a cardiogenic cause of this hypoperfusion and elevated lactate. She clinically had no clear alternative etiology for this issue. And finally, the cardiac images really helped us sort out what aspect of her cardiac function was really impaired here. And we felt that in this case, it was mostly related to forward failure or a problem with her cardiac output. secondary to compromised LV filling, increased regurgitant fraction, and the overall decreased systolic function that she came in with. And so in this situation, rather than being a problem with backward failure and congestion, this was a cardiac output and forward failure issue. And this helped inform our treatment plan then. So what we suggested to the team is that they need to be a little bit more aggressive with their afterload reduction. Add another antihypertensive to her regimen and start to bring down her blood pressure. Control her heart rate. We needed to allow for better filling time to accommodate that stiff ventricle. And so we suggested that they continue to aggressively work on getting that heart rate down with the metoprolol that was already started. We also suggested that they consider drainage of the pleural effusion. By reducing that intrathoracic pressure, you're going to allow better filling of that left ventricle. And finally, we suggested that they avoid that Lasix fluid infusion yo-yo. Congestion or backward failure was not felt to be a big part of this problem. And so treating heart failure is not all about just Lasix. In addition, we felt that she might actually have a requisite need for increased filling pressures on the basis of her stiff ventricle. And finally, she had a stable respiratory status, so a lack of compelling reason to trial diuretics in the first place.
I feel like you're really making the case for putting the color on, which is not always routinely done, and really you already got the probe on there, look at the valves and what they're doing, and it can really help inform the hemodynamic assessment. I'm not sure that you could get such a nuanced and detailed explanation for, someone who's basically in cardiogenic, like a shock-like state, or, poor cardiac output, even with a good blood pressure, hypoperfusion, without getting the valvular studies that you did.
Yeah, 100%. It is a bit of a kind of a next level skill, but I think so helpful. And, I think you raised a good point there that we often just associate heart failure with congestion. But heart failure has many phenotypes, and it really is the ultrasound that gives us those extra data points that can help us sort that out. Mm-hmm. So the last thing then I want to talk about here is just move on quickly to venous thromboembolic disease. And certainly this is something that as physicians in the hospital that we're thinking about all the time, but in particular in the context of COVID. Venous thromboembolic disease there's definitely an increased incidence in COVID patients that are admitted to hospital, in particular in those that are in the critical care units. One thing to note though, is that clots may form directly in the lung. There's something about COVID that we can see clots in the lungs without seeing them initially formed in those deep veins. Nevertheless, the deep venous clots are still particularly important in the context of COVID. What's interesting is that a lot of the evidence now is suggesting that we should be treating these patients prophylactically with full therapeutic doses of anticoagulation. And so at our hospital, the recommendation is that COVID patients requiring low flow oxygen who are admitted to hospital that don't have a high risk of bleeding and are not requiring organ support should be on full doses of anticoagulation. The other thing that's really come into vogue, or we've had to struggle with, is these vaccine-related complications, or VIT, vaccine-induced thrombotic thrombocytopenia. It's a rare complication following adenovirus vector COVID-19 vaccines. It's similar to HIT, or heparin-induced thrombocytopenia. What's interesting is these patients may present with unusual clots, such as those in the cerebral sinuses, but do see clots in regular DVT patterns as well as arterial clots as well. And so I just want to pass this over to Oron here to talk about a quick video here.
Well, yeah, this is a quick how-to to do a DVT scan. So I'm starting in the groin, and in the center you can see you really want to find a single artery, single vein. So common fem artery, common femoral vein, and you need to find the saphenous takeoff and branching as your most proximal point. And what you see is I'm compressing from there and going down the leg. I'm going rather fast just to kind of show the quick technique. And but you really need to see the walls of the vein kiss and completely collapse as you're moving down the leg through. I like to go the whole adductor canal if I can, with the femoral vein in view, having the walls of the vein collapse. And the other part of this scan that's important is to make sure you get the full deep vein system by going to the popliteal. So there's the popliteal artery with the vein on top. We say pop on top. and doing a compression there and making sure the walls collapse and really kiss each other to make sure there's no thrombus inside.
Thanks, Horon. So let's just take a look at some images here then. So starting up here on the left side, we do have a very proximal look at the femoral vein, placing that in the center of the screen and doing a good compression effort. And you can see with that compression that we lose the lumen completely. And so can say that there is no clot in that particular region. As we continue down the leg though, we get to this area over here on the right, where we have, once again, that femoral vein as well as the artery. And as we compress here, we can see that that femoral vein is just not compressing completely. And we know that this, we've used enough compression here because we're starting to see that the artery is being indented there. As we continue down then, we see a same phenomenon here where we're not seeing collapse of that vein as we're putting on that compression. And what's nice here is that we can then add some color, which isn't absolutely necessary because we've already documented that there's a clot here. But what you're able to show then is that there's complete occlusion of this vessel because there is no color within that vessel whatsoever. Then when we move down to the popliteal region here, we can see once again a pop on top, or that popliteal vein on top of the artery here. And you can actually see in the vein here that there is this echogenic material within the lumen of the vein. And once again, as there's compression and we see that indentation of the artery, there is no loss of the lumen of that vessel. And so once again, this is positive for a DVT within the popliteal vein. As we march down the leg a little bit, we see the same thing. We should continue down to that trifurcation of the vessel. And then ultimately here on the right side, once again, adding a little bit of color, we see that artery light up. But once again, full occlusion of the vessel here without any color flow. Now remember, you can have color flow in the vein with a DVT. It just means that you don't have a full occlusion of the vessel at that particular region. So a positive study clearly for deep vein thrombosis in the leg. So just to summarize what we've talked about here today then, B lines are not specific to cardiogenic pulmonary edema. B lines are seen in interstitial syndromes. And a pleural assessment can help us discriminate between those cardiogenic and non-cardiogenic causes of interstitial syndromes. And in the right clinical scenario, really gives us a clue as to whether or not a patient has a high probability of COVID. The absence of B lines, however, does not rule out decompensated heart failure. We often associate B lines with heart failure, but clearly there are multiple phenotypes of heart failure. And the particular case that we looked at, there were no B lines. This was more of a case of forward heart failure. In suspected heart failure, there is more to cardiac scanning than assessing systolic function. And so we nicely demonstrated there by looking at the actual myocardium itself or looking at the valves in a bit more detail that we acquired a lot of useful information that helped us sort out what that patient's phenotype was. And finally, venous thromboembolic disease can be diagnosed with B-mode compression exam in 2 zones, looking at the femoral as well as the popliteal. Adding color is informative if you're looking at describing whether or not it's a completely occlusive clot, but not necessary to make the diagnosis. Thank you, and that's where we'll end the talk here for right now. I'll pass it back to Oran.
Yeah, thanks so much, Shane, for a really great presentation. And, we're just really skimming the surface here of hemodynamic assessment and what can be done with the ultrasound at the bedside for both the lungs, cardiac, and including DVT as part of that hemodynamic assessment, and really enabling the cardiac and pulmonary imaging in a wide variety of environments. I want to encourage everyone, we're going to have some time for Q&A at the end, to use the Q&A down below, and we'll save some time, make sure to get to the questions with Shane here in a moment. I was going to jump in and show, Clarice has made it pretty easy now to do a full hemodynamic assessment. And I was going to show a quick demo of how to obtain those scans with one of the new features that they've built for us. I'm going to select here. It's called an auto select that they'll be releasing on the app. And what it can do is it can allow me to do a full hemodynamic assessment. So if I want to do a lung exam, like Dr. Arishenkoff was showing us, there we go. I'll get the pleural line and I can do my assessment of the lung zones down on the side. And then, I would repeat the same scan on the other side. If I could, I would sit the patient up, do the back. Now I'm going to come and do a cardiac scan. And it will automatically kind of switch into, on the same probe, get me my cardiac views, start with my parasternal. I can optimize, do my calculations there. Maybe rotate, do a short axis. If I'm in the emergency department, I might be, if I'm a hemodynamically unstable patient, I might want to be looking for free fluid in the abdomen. So I'll come down and it's automatically choosing the preset for me for the abdominal organs, where I can scan, say, the tip of the liver, looking for free fluid in the abdomen. Maybe I'm still an IVC believer and I'm going to take a quick look at the IVC, check for assessment there. And for full comprehensive evaluation, if I'm worried about right heart strain, or if it's for a DVT that I want to know, I can even take the probe and slap it on maybe the popliteal or the inguinal region as needed, and get my view here of the popliteal vein right here pop on top with a nice fully compressible, and scan it up towards the adductor canal. Pretty convenient feature to let less touching of the probe and quicker scanning and quicker information at the bedside. So I'm going to hand it back over to Janez here to take it home. And again, please use the Q&A at the bottom, and we will make sure to save some time here for Q&A after Janez gives us a bit more information.
Thank you, Dr. Frankel and Chris, for the live demo. And thank you also to Dr. Arishenkoff for sharing your ultrasound techniques and helping us hone our image interpretation and diagnostic skills. Before we start our live Q&A, I'd like to take a minute to tell you a bit more about our Clarius C3 HD multi-purpose microconvex wireless scanner that you saw in the live demo. Just like our full family of products that include linear, phased array, and endocavity scanners, the Clarius C3 delivers the highest definition ultrasound imaging in a wireless, affordable, and easy to use system. Clarius is unrivaled for image quality in a handheld ultrasound. It shows you the fine details you need to quickly investigate an area of concern and make a confident diagnosis to expedite the right treatment plan. Each scanner is designed with 8 beamformers that deliver the image quality only found in traditional systems, but at a fraction of the cost. Artificial intelligence replaces complex knobs and buttons, making your scanners fast and easy to learn and use. Clarius is also wireless, freeing up space with zero footprint for high portability to scan patients at the bedside. You get free movement with no wires getting in the way or infecting your sterile prep area. And with no wires, it makes it so much faster to clean and disinfect as well. Only Clarius delivers wireless scanners with a free ecosystem that includes free apps for your iOS and Android devices with free updates, unlimited cloud storage to capture and manage your exams, and for unlimited users at no additional cost. Clarius Live delivers one-click telemedicine if you'd like to share live scanning with a colleague for a second opinion. And with no subscription fees, Clarius HD scanners are ultra affordable. And as mentioned by Oran a moment ago, we recently released the Clarius Ultrasound app 8.0 that includes dozens of new features, including advanced innovations made possible by machine learning and artificial intelligence. We're particularly excited about the auto preset AI, which you just saw in action today, that recognizes anatomy at a macro level and selects the appropriate preset to automatically optimize imaging in real time. Now, before we begin our live Q&A with Dr. Arishenkoff and Dr. Frankel, and you can ask your questions anytime now using the questions icon at the bottom of your screen. But just before we start the Q&A, I'd like to take a minute to invite you to ask for more information on your journey to using POCUS and bringing POCUS to your daily practice. We are certainly more than happy to give you more information that you may need. So if you'd like to request quote and pricing information, Clarius is available in 90 countries worldwide, and pricing varies by currency. So please do select that option if you'd like us to send you pricing information on Clarius HD. If you'd like to speak to an expert about which scanner might be ideal for your practice, we'd be happy to talk to you about that. If you'd like to discuss scanner features and the advantages of a handheld system, we'd be happy to chat with you about that. If you'd like to book a live demo, we'd be able to book a Zoom demo with you so you can see Clarius scanning live in action with one of our sonographers. Or you can watch more tutorials. If you select that option, we will send you more tutorial videos from Clarius Classroom. I'll give you 5 more seconds to weigh in. 5, 4, 3, 2, 1. We're getting so many more people voting. I'll give you 2 more seconds. 1, 2. All right, I will end the poll now. And if you didn't get a chance to answer the poll, you can go ahead and go to our website to ask for a demo at any time. One more poll before we go to our live Q&A. This one to invite you to our webinar in 2 weeks' time entitled Pragmatic MSK Ultrasound Scanning, the Rotator Interval, Common Extender Tendon, and Patellar Tendon. We've teamed up with Sonoskills, Europe's leading musculoskeletal ultrasound educators. And on June 29th, in just 2 weeks, renowned educator Mark Schmidt will teach anatomy, sonoanatomy, technical scanning skills, and pathologies common to the shoulder, elbow, and knee. We'll take a look at imaging of muscles, tendons, ligaments, and joints at rest and in motion to build confidence in diagnosing and ruling out musculoskeletal pathology. Save your seat with this poll, and we will send you your registration email confirmation in the coming days. I'll give you 3 more seconds to save your seat for our next webinar. 3, 2, 1. Now on to our live Q&A. We've got just about 10 minutes. I'd like to welcome back Dr. Arishenkoff and Dr. Frankel. I want to let everyone know that in the coming days, we will send you a copy of the PowerPoint deck that we presented today in PDF format, as well as a recording of today's session. So Dr. Frankel, I'd like to invite you to moderate our Q&A, and I'd like to invite all of our participants today to use the questions icon in the menu to ask your questions.
Okay, great. Let's jump right in. There's a couple questions about the IVC. Someone made a comment about me saying if you're still an IVC believer, and I realized maybe I kind of took it a little too far there.
Come on, Ron, you're talking to some internal medicine folks here. You got to be careful.
I know. It's
hey,
like
listen, you know, I think it's great, and I saw that one, and I also saw a question about why didn't you include it in your talk? The actual image, and the quick answer for the image one is that we needed to make sure that we stayed within a time slot. And so I had some more images that I wanted to share and that I wanted to talk about ad nauseum, but I had to be a little bit more succinct. And so we chose to focus really in on the lung and the cardiac scanning for that one. But I could have easily inserted the IVC into that as well. And, you know, I think the IVC is one of those things that is helpful, but it is associated with a lot of pitfalls. And I think if it's not used carefully, and typically it isn't, it can get you into a whole lot of trouble. And so I would suggest that the IVC is still helpful. I do use it. I regularly do find that it is informative, but I also regularly find that it is contaminated and that I have to exclude it, or that it's very difficult to find or insert. And I certainly I certainly see a lot of people use it inappropriately.
I think that's fair. I teach that the IVC is there to check your work. So you make your hemodynamic assessment, lung and cardiac scan, and then I use the IVC to, I predict what it's going to look like. And then if I'm surprised, then I think harder about what did I miss or what did I misinterpret.
Yeah.
Great. There was an interesting question, one of your answer about prevalence, and what prevalence do you think is required for these scans to be predictive? I presume it's for COVID.
Yeah, I think they did mention that after there too, and they in the paper, I don't believe, I'd have to go back and look now, but I don't believe they actually even told us what the exact prevalence was at a time, but this was during a wave, right? Where the way that I interpreted it was when we were seeing between 5 and 10 COVID patients admitted per day to the COVID ward at VGH, that was a high prevalence period where you know, we're nearing probably 50% of those people coming in with shortness of breath as their number, as the reason for presentation. That's a high prevalence period. And certainly there's nothing specific about a lot of those signs that we were talking about, right? The interrupted, irregular, thickened pleural line with B lines can be seen in other viral pneumonias. It can be seen in interstitial lung diseases. It can be seen in other inflammatory conditions like organizing pneumonias, right? So you do have to be thoughtful. And, you know, if we get to a point this summer here where we're only getting a COVID case once a week, clearly that is not going to be good enough to suggest or rely on for a diagnosis of COVID.
Yeah, I mean, just yesterday, I had, you know, and our numbers are going down a lot, but I've seen so many multifocal pneumonias, you know, more than I had seen in my entire career this past year, like everyone. And now it's to the point where I put the probe on their chest and it's like, oh, COVID, you know, and maybe I'm worried that, you know, I will keep that cognitive bias even moving ahead when I should think outside of the box. Certainly, you know, the next pandemic that comes, whatever it is, if it's influenza or something, you know, we'll be way more prepared at diagnosing these multifocal viral pneumonias.
I think one of the things, if I could just offer too, is I've gone back to look at the literature just as far as what in the imaging literature, what do pneumonias look like on CT? And most of them are actually either an interstitial or bronchopneumonia type pattern rather than full lobar pneumonia pattern, right? And so ultimately, even in bacterial pneumonias, many of those are going to have the appearance of an interstitial syndrome, right? And so we need to be aware of what it is that we're looking for. Full large areas of hepatization are not the most common way that pneumonia is going to present.
Right. And maybe that's, I mean, I won't even go there. So a couple of questions I'm going to lump together. Maybe I'll take these about pre-hospital use and outpatient use. You know, do you do any clinic work right now, Shane? I'm not sure if you do. You're only inpatient right now?
Only very occasionally.
Yeah, I would say 100%, especially with handheld point of care ultrasound. You know, one of its amazing powers is to take this kind of diagnostic ability anywhere. So if you work inpatient and outpatient, pre-hospital, the probes can go anywhere and diagnosing people right away. In Italy, they've been doing triage protocols outside of the hospital where people just take a probe and they go out into the community and are scanning people like at home. They're checking on them. How are their B lines? Are their B lines improving? Are they getting better aeration? Do they need to go back into the hospital? There's a lot of role for outside, and you don't need the cart and wheel around the cart or take it in a suitcase like you used to anymore. So it's really a game changer that way. What do you, I guess, we talked about the lung scanning protocol. Is that the lung scanning protocol that you use now every time, what you showed us?
Yeah, you know, somebody once told me when I asked them, where do you put the probe for a lung scan? It's wherever you would be looking for pathology, right? And so I think the thing to take away from this is that a lot of these protocols are designed for studies, right? So that they can be consistent. But really when it comes down to it, my question whenever I go to the bedside is how sensitive do I need to be, right? And where is the pathology? If all I was interested in is whether or not there was a pneumothorax, I would scan the least dependent region of the chest and then be done, right? But if I've got somebody who is short of breath, maybe mildly hypoxic, it could be just a small pneumonia or something along those lines, I need to cover more area. So absolutely, my general lung scan includes a survey of the anterior, lateral, and posterior chest. And if I see an area that is abnormal, I start to slide around in that region more to cover more surface area, because that area that's initially abnormal might be associated with something even more interesting, and I might find other pathology in that region. It's only when I have a normal pleural line and A lines with good lung sliding that I just skip to the next zone.
Great, and we're at the top of the hour. I'm going to squeeze one more question in. What transducer is the best, or scanner is the best for lung scanning?
This is hotly debated amongst
Yeah.
POCUS nerds. I'll tell you why I like the curvilinear for general lung scan. Number one, it's got the depth of penetration that we need, so better than just a linear array that has or a high frequency transducer. You do need to be able to get that distance to look for pleural effusions and the extent of a lobar pneumonia or something. I also like it because it does a better job than the phased array at examining the pleural line, right? The phased array with that sector image sometimes doesn't catch very much of that pleural line, and you don't get the same level of detail. And as I've mentioned here, to me, lung scanning is in a big way about looking at the pleural line, because the pleural line has so much to offer with respect to helping us sort out these conditions. So I would say hands down, as a general tool, it's the curvilinear.
Yeah, and I'm kind of with you that I think the curvilinear can do more. The phased array does more cardiac, does cardiac better, but it does everything else maybe not. But see, the curvilinear can really do everything. You kind of get the maximum use in a single transducer.
Agreed.
Yeah. Great. Well, I think we're out of time. Thanks so much.
Yes, thank you so much. We've now reached the top of the hour. If we didn't get to your question, we'll follow up with you by email in the coming week. A reminder that you will all receive a copy of the slides and webinar recording by email in the coming days. We hope to see you again in 2 weeks with Dr. Frankel and Mark Schmitz for the live webinar, Practical MSK Ultrasound, scanning the rotator interval, common extender tendon, and patellar tendon. I would like to extend a huge thank you to Dr. Arishenkoff and Dr. Frankel for today's wonderful presentation, and invite everyone to have a wonderful rest of your day. Thank you.
Bye, everybody.
Thanks.